So the question driving this work was just, what are the facilitators and challenges experienced by the home care leading projects as they plan for implementation? So this is the basket of methods that we used for this work. So we started with a document review, so reviewing funding applications, the logic models, and so on of the programs, just to understand what these programs were aiming to accomplish. And we decided to do a deep dive into 3 teams with monthly observations of key planning meetings and interviews scheduled twice over the evaluation period. We've essentially finished with one of these, the pre-implementation phase, and that's what we're going to be reporting on today. And we're doing focus groups with the other 4 that sort of coincide with the timing of the interviews. We're also doing reflective check-ins with all the teams. So these were monthly at first and now quarterly, given the more established pace of the projects. So about 45 participant voices are going to be featured here, well, in synthesized form, but across the leading projects. And, these are the voices that really contributed to the results that you're going to see. So these are the key themes that emerged. So implementation facilitators and challenges included planned levers of change, and Kaylee took you through some of these at the beginning. In relationship building, leadership, building on testing and managing change, flexibility and tailoring of the model, physician engagement, risk and uncertainty, and commitment and motivation to integration. So these are really both facilitators and challenges, as you can imagine, except perhaps for risk and uncertainty, that's more obviously a challenge. And the planned levers of change, we hope will, be just a facilitator. So obviously, the presence of many of these things, take relationship building, for instance, its presence was a facilitator, its absence a challenge, right? And they showed up in some form to some degree in a majority of teams. They're not immutable, so what might be first experienced as a challenge could obviously be resolved over time, mitigated over time, and then maybe even turn into a strength. And they cannot really be understood in isolation from each other. So relationship building, for instance, may be contingent on other things, maybe robust leadership, which then might help you navigate uncertain policy environments or whatever it is, and so on. So relationship building. So I'm just going to pick about 4 or 5 of these themes, but I think you'll see glimmers, shades of the others sort of coming through as well. This slide focuses on partners, and the next slide, relationship building happening as it relates to providers, because obviously relationship building happens at these different levels. So it won't come as any surprise to know that mature partner relationships correlated with a shared vision. So here's a hospital leader saying, whenever we, the hospital, ask you at CCSS, obviously this was collected before it turned into OH at home. Whenever we ask you to take something on, you start from yes, and then you figure out how to do it. I think that's a bit unusual as far as a relationship between hospital and home care is concerned. And an HCCSS leader from the same team saying, when you come to an in-person collaborative meeting for our OHT, it's like a party. It really is a unique experience. However, there were certain limits to sharing and collaboration that were experienced by a number of teams as well, right? So here's a leader saying, is OH at Home truly a willing and contributory partner to these projects? They still hold a lot of power and sway over the outcome of the project. And we see hesitation in how much buy-in we're getting. HSPs haven't done this before. I feel like they've asked us, do you accept the set of services that we're offering? And our response is, yeah. That looks pretty good, but we don't know what we don't know. That just feels like an example of OH at Home saying, sure, we'll do this, we'll do exactly what we're asked to do. Well, it would have felt a bit more collaborative for there to actually be a conversation between the HSP and OH at Home to help them understand what's required to run home care. So 2 very different types of relationships, as you can see, with the same organizational partner, albeit with different people at the local level. And unfortunately, the experience on the left was a bit more unique. So building on existing innovations that leading projects knew were working well, this was something many projects did, and it helped because it provided them with a sense of confidence. And test running planned innovations was also helpful. It was something I think one team was able to do really well. Others were able to do certain aspects of planned innovations, and doing so really helped identify gaps. So you had, for instance, a community leader realizing, what, the care coordinator is giving one message, and we, the partner service provider, were giving a completely different message, or the realization that physicians were being contacted a lot. And this allowed for solutions to be developed, even in this pre-implementation phase, right? So coordinators, perhaps they decided, could call physicians' offices and have the receptionist triage questions. Mentorship could perhaps be provided by an experienced navigator who could accompany not as experienced care coordinators, perhaps, to visits in tandem with clients. Okay, change management sessions helped a lot as well. They provided an opportunity to introduce the project and communicate changes. It allowed providers from different organizations to meet, to begin team building, to ask questions, voice concerns, provide input into plans, and so on. So here's an administrator, hospital administrator, saying, well, change is hard because there's so much ambiguity, but to be uncertain together and to ask the questions in one space and receive that training, well, I can see the benefits of that. All right, so flexibility and tailoring of the model. So being able to test changes to care delivery on the ground really helped. It allowed teams to flexibly tailor their model, whether it is, tailoring it by site or whatever it was, right? And the lack of flexibility really came in the way of relationship building and this development of a shared vision. So here's an OHT leader saying, if we're thinking about this as the Thanksgiving dinner table, well, HCCS is at the table, but limited in their ability to eat the turkey, constrained by, I think, a culture of risk avoidance, constrained by a directive to standardize provincially, despite there being 58 OHTs and 7 leading practices that are by design supposed to be different from each other. And this obviously would have an impact on this relationship building piece. However, an experienced leader, and you see this leadership theme coming across here, they might be able to creatively negotiate a tension between innovation and harmonization. So you're releasing this tension between the need for flexibility, which is a boon, and yet this impetus to standardize, which has its own benefits. So here's an HCCSS leader saying, across our organization at CCSS, we're being told to adopt a consistent approach so that all 7 of our home and community care programs are approaching this in the same way. So for example, we would do a light touch eligibility and determination of what the patient actually needs, and then send it over to the leading project. And I'm not sure that works for every population. I'm trying to find areas where there's wiggle room, find ways to influence things from a home and community care perspective, but still fit within the rules. Risk, uncertainty, and commitment. This is really the fusion of 2 different themes. So risk and uncertainty being one, and commitment to the model being a second one, despite this atmosphere of risk and uncertainty. So risk and uncertainty came in the form of, for example, delays, which put relationships at risk and frustrated momentum. So here's a HCCSS leader saying the service providers, used to show up faithfully. Like 2 summers ago, they were at every meeting, would get people from their head office here. But now it's been crickets. We can't even get them to attend locally because they've moved on to other priorities, because this is delay. And then, so the SBO procurement process and engagement timeline, this also contributed to a sense of certainty, because, some teams were actually trying to leverage their SBO's knowledge and insights for the leading project innovation itself. And their SBO was a key partner, right? It'd be at partnership meetings and so on. But now they couldn't talk to them because of this procurement process that was ongoing. And there was also a good possibility that their existing SBO might not actually be the one that was selected in the end. So here's a leading project leader saying, we have been feverishly working with our newly announced SBO. So this is a team that ended up with a new SBO partner to figure out privacy agreements, digital solutions. So we're only now getting to what is the transitional lead going to do? What is the care coordinator going to do? But because of that blackout period, we could not advance any of these conversations. We didn't know how well versed our SBO partner was going to be. I understand the RFP and procurement rules, but just the way that the timing fell, it's an unfortunate situation. So despite this, you did, however, see many leading projects really articulate this commitment they felt to this transformative vision that the leading projects represented. So here's a HCCSS leader saying, we're working as though the project's already been funded, and it's not. So you don't do that unless you have significant trust among the partners. So if the hospital doesn't approve it at their board meeting tonight, the leading project partners have said, well, we're going to move forward with it anyway. It just means that we may have to adjust a bit, that maybe we won't be knee deep in it, we'll just be shin deep in it. Okay, so in conclusion, this is just trying to articulate a vision for the future. So a number of the themes that you're seeing here really center around this idea of rules, so whether it's protocols around standardization or the SBO selection process or whatever it is. And there's this underlying concern that rules that would distance from the local context don't perhaps make sense either for providers, as you see in this first quote on the left, or for patients, as you see in the second quote. Okay, so first you have a hospital leader saying home care modernization is removing some of the rules-based thinking that care coordinators are just authorizers of service, that this can't be funded or this can't be provided because it doesn't fit in our rule-based system. It is one of the things we are unfettered by in our hospital-run home care program for the most part. When the team sometimes sheepishly comes to me and says, in order to get this person home, we need to get them a mattress. So we went and bought a mattress from Sleep Country and had it delivered. Is that okay? I'm like, yeah, that's okay, because at least they can say they would have stayed 5 more days in hospital at $1,000 a day versus the $133 you've spent on a mattress. And the outcome of rules-based thinking is not person-centered care. And on the right here, you have a PFAT member talking about the care her mom is receiving. So she says, I have workers from the SBO here sitting with my mother, listening to music, doing this and the other thing while I run around cleaning, doing her laundry, putting in the orders for her supplies and on. And I think, shouldn't I be the one sitting with my mom? Shouldn't somebody else be doing these other things? And they, the PSWs, are very, very limited in what they can do. Once I had made the PSW a cup of tea, as it puts you in a better mood for caring for my mother. And as she left, she says, oh, I put my cup in the kitchen for you. Okay, but there are things that they're not allowed to do that I kind of shake my head over. It doesn't cost any more money. It's a better use of the worker's time, but we don't touch that. We're looking at the structure. Should it be this agency or that agency who's in charge of home care? So essentially, leading projects were saying in order to truly transform home care in a meaningful way, changes need to be made that sort of go beyond the bureaucratic structures, right? So changes that are perhaps a bit more ambitious than what was originally envisaged. So moving on to recommendations. So this one is directed at OHT stakeholders, and the next two will be directed at system stakeholders. So, perhaps signal upfront to on-the-ground providers that their patience and buy-in will be required to identify and work through early implementation challenges so that they are aware that the partnership, their partnership will be required for eventual seamless patient and provider experience. So this hopefully, for instance, will preempt physicians trying to engage in gatekeeping and discouraging colleagues from joining the program until all the wrinkles are ironed out. Then have open conversations to understand the scope for and benefits of both a tailored and standardized approach in different contexts. And this recommendation really emerged because of this connect we were noticing between OH at Home and the leading projects, with OH at Home sort of really pushing for standardization because that's what they had been tasked with doing, and leading projects pushing back because they thought the whole point of this exercise was to try different approaches, and a one-size-fits-all approach suddenly didn't seem like it would work for them. Okay, then unexpected SBO changes will require attention to developing new trusting relationships. That was not part of original plans, perhaps, but this may require additional work and time, but it's important given the evidence that trust really is a key enabler. So moving on to recommendations for system stakeholders. So just, I guess, start off being aware that many OHT stakeholders thought that the leading projects did not necessarily address key issues pertinent to either patients or providers, whether it's PSW roles or privacy regulations. And then also be aware that project delays and the lack of directional consistency and dependable funding really frustrated OHT's ability to engage stakeholders and hindered understanding of long-term vision. So when we presented these recommendations, recently back to the leading projects, it was this lack of directional inconsistency that they really honed in on. So we did have it in the background of our recommendations, but we sort of brought it to foreground because they really flagged it for us. Flag expected outcomes in relation to timelines. So what is expected in the short, medium, and long term. And hopefully doing this will mitigate OHD anxieties by acknowledging that certain impacts may take time while providing a realistic roadmap of direction and accountability. So the tense relationship between many OHTs and OH at home needs to be addressed for meaningful collaboration going forward. So just some ideas here. Is there scope for working on timely responses to requests given interdependencies? Is there scope for getting all stakeholders on the same page about the legal framework within which OH at home operates to mitigate finger pointing? Is there scope for collaborative guidance provided to leading projects and HSPs to help them understand the intricacies of what is involved in delivering home care?